Good morning, everyone. Thank you very much for joining us this morning. Welcome to our UCT-Africa virtual ENT meetings. So we just are allowing some more people to join. We'll give it another minute or two. This morning, we're having a talk on Laryngomalacia given by one of our registrars, Dr. Agata Bizos. So we're going to start the meeting in a few minutes. And if you would kindly just keep your microphones muted. If you are muted as you speak, we'll unmute everyone at the end of the presentation. The time is now 20 minutes past, so perhaps we should start. Okay, so without further ado, I'm going to hand over to Agata to start the presentation.
Good morning, everyone, and welcome to our forum. I'm Dr. Agata Bizos, and this morning I'll be speaking on Laryngomalacia, a deep dive. I'd just like to acknowledge Professor Shazia Pia, who has inspired this talk with some research that we are busy with. So just a disclosure, consent has been obtained, content is referenced, and there is no intent for copyright infringement. Laryngomalacia is the most common cause of pediatric stridor in children. It's the most frequent reason for referral to the pediatric ENT. And it was first described by Mackenzie in 1919. In the same year, over 100 years ago, when the Treaty of Versailles was signed and the World War I was ended. Its prevalence is unknown, but males are documented as being twice as affected, and almost half of severe laryngomalacia is associated with comorbidities. Its etiology is not fully understood. It was originally thought to be due to immature cartilage, but it is now theorized that laryngomalacia is caused by hypertonia due to abnormal sensoromotor integrative function. On clinical presentation, the child will most always inevitably present with stridor. This stridor is inspiratory and variable. It worsens when excited and feeding, and its intensity and frequency does not imply its severity. It gradually develops during the first few weeks of life, and it peaks in severity at around 6 months of age. It's associated with feeding issues, almost always associated with gastroesophageal reflux disease, and can be associated with sleep apnea. The clinician should inquire about weight gain, feeding issues, cyanotic episodes, poor prolonged feeding, aspiration, and sleep-disordered breathing. The voice should be unaffected, and the neonate should have a normal cry. The diagnosis of laryngomalacia is confirmed with flexible nasal endoscopy. This is the gold standard, and almost in over 20% of flexible scopes of these children, a secondary lesion can be identified. The classical findings of laryngomalacia on flexible nasal endoscopy include foreshortened aryepiglottic folds, aryeretinoid prolapse, and an omega-shaped epiglottis. And this is just a dynamic video showing laryngomalacia in action on flexible nasal endoscopy. Supraglottic prolapse is associated with laryngomalacia, and this hypertonia of the larynx allows for prolapse of the supraglottic airway, which leads to obstructive airway symptoms. Anatomically redundant supraglottic soft tissues collapse on inspiration and cause supraglottic airway obstruction. Associated reflux is is common with these children, and so it accompanies laryngomalacia with or without surgery. It's closely related, and one may exacerbate the other. So untreated gastroesophageal reflux disease may worsen symptoms and delay healing. And so reflux diseases and control is important both pre and post-operatively. Infants with severe laryngomalacia have symptoms that are more clinically relevant and concerning, including recurrent cyanosis, apneic pauses, feeding difficulty, aspiration, and failure to thrive. And in other investigations for these children, a direct laryngotracheobronchoscopy is not usually required, as the diagnosis should be made on flexible nasal endoscopy, but can be indicated in an atypical history with a suspicion of distal airway pathology and where one is unable to make a diagnosis. Sleep studies or overnight saturation studies can be indicated for children who have concurrent obstructive sleep apnea or sleep disordered breathing. The management of laryngomalacia is individualized and usually conservative. Most patients affected by mild or moderate laryngomalacia are self-limited and may be treated conservatively with acid suppression therapy and observation, and routine and regular follow-up until resolution. However, in 20% of severe cases, surgery is required. And diagnosis, so in these cases, diagnosis should be confirmed with DLTB. The trial of anti-reflux treatment should be started, and for non-responders or children with present sleep apnea and severe failure to thrive, as well as feeding difficulties, surgery is indicated. Surgical options include supraglottoplasty, which is the gold standard of surgical care, and cold steel. The cold steel method is preferred in our institution. Contraindications to supraglottoplasty include an underlying neurological condition, severe aspiration, or abnormal vocal cord movement with aspiration. Selection of these patients is of utmost importance, as waiting for the success of a supraglottoplasty will just delay an inevitable tracheostomy. So as I said before, patient selection is of utmost importance, and with the correct patient, you can achieve excellent results. It's always important to remember that less is more in this surgery, and it's a stepwise approach where the first step is the division of the aryepiglottic folds, and usually this is sufficient to resolve symptoms. Complications of this surgery are quite rare, less than 8%, and supraglottic stenosis, aspiration, and synechia are more related to laser-related damage as opposed to cold steel. Other complications include granulomas, or the surgery being unsuccessful with failure to thrive, in which case a tracheostomy is then indicated, and then once a tracheostomy is performed, tracheostomy-related complications can occur. So this is just an example of endoscopic right aryepiglottic fold trim with cold steel. And the results post-supraglottoplasty, which show a beautiful open airway. Here's another example of pre and post-supraglottoplasty, which again depicts the excellent results that can be achieved with this procedure. So there are different types of laryngomalacia. Type 1, it can be classified as having shortened area epiglottic folds, and so simple incision of the shortened area epiglottic folds is the mainstay of treatment with a success rate of 90%. And in laryngomalacia type 2, where there can be redundant supraglottic mucosa, then excision of redundant mucosa using laryngeal graspers and scissors is indicated. As said before, most cases are successfully treated by the above-mentioned 2 procedures. However, occasionally an epiglottoplexy is required, and this can be done using CO2 laser to burn the base of the lingual surface of the epiglottis, or by placing a suture between the lingual surface of the epiglottis at the tongue base. So at our institution at Red Cross Hospital, we've developed standard operating procedure for airway patients in the ICU because intraoperative care is important, but post-operative care is as important. And so when transferring the patient, anesthetic requirements on transfer include a nasogastric tube, Presidex infusion, as well as a microcuff used for intubation. In the ICU, it's important post-operatively to have a chest X-ray on admission with regular soft suctioning of the oral cavity. And once extubated, ceprofloxacin, dexamethasone, and saline nibs are required for 5 days with the addition of adrenaline, saline nibs. Patients should be extubated to CPAP, and if at all the child needs to be re-intubated, then the surgeon, ENT surgeon, should be informed and instructions should be given from the surgeon, as intubation may damage the repair site. The position of the patient post-operatively in the ICU includes 30-degree head elevation with head in the forward-facing position and head blocks for the first 48 hours with no shoulder roll required, and the patient should be sedated with no movement, and a Presidex infusion can aid in this, which should be only start to be weaned at 24 hours post-op. Other relevant medication required post-operatively include a proton pump inhibitors and adequate analgesia, and antibiotic coverage is required, which Kefsol is adequate in 3 divided doses for the first 48 hours unless otherwise specified. These children post-operatively should have no oral feeding until the child is discharged to the ward with nasogastric feeds only. So in summary, laryngomalacia is the most common condition in children causing stridor, and treatment is individualized, but is unusually medical, where active observation and regular follow-ups with growth monitoring is required. Severity of the disease must be assessed and managed further, as this will avoid failure to thrive and apnea-related pulmonary hypertension, and supraglottoplasty is the cure where indicated, where resolution of stridor, improvement of sleep apnea parameters, and improved growth have been portrayed. These are my references.
Thanks so much, Aggie. We're just going to unmute everyone. Just give us a second. Are there any comments or questions on the floor? Everyone should be able to unmute themselves. Perhaps we have some comments from people joining the meeting. Maybe Prof. Pierre, I don't know if you're able to, if you want to make a comment, or Dr. McGuire.
Yeah, and just really well done, Aggie. That's a very good, comprehensive, and very descriptive, visually sound presentation. It's really lovely. I think adding the standard operating procedure at the end is really good also, because you're only as good as your post-op care sometimes. So thanks very much. I think the one thing just to add is sometimes some kids don't actually outgrow their laryngomalacia and they present a lot later. And so I've seen this now. And the oldest person I've actually done a supraglottoplasty on was about, I think, a 12-year-old. And it's very rare, but you see them. And they usually present with recurrent croup as they get older, and just the symptoms don't fit. And once you see the laryngomalacia that hasn't outgrown, you then get a history of prematurity and many other things. But certainly for the general laryngomalacia presentation, they present usually at around birth and in the first few months of life. Thanks, Aggie. That was lovely.
Thanks, Prof. Pierre. Any other comments on the floor? Maybe Dr. Maguire, I don't know if you have any comments.
I think she's not here. We just seem to be, we like the picture, so we've left it on.
About the question, so you mentioned that the gastroesophageal reflux is more common. But is that cause and effect, or is it just because you're looking for it? Is it more common, at least in the general population at that age? So I would like to know, because what would the mechanism be? Why would it be common?
So it's reported to be in about 80% of children presenting with laryngomalacia. And the pathophysiology is associated that the acid reflux actually exposes the laryngeal the chemoreceptors on the larynx, which exacerbates the laryngomalacia.
Okay. So it's more common than it is. So Charlotte?
Sorry, no, go ahead. I was just going to add something, but yeah, that's pretty much what Aggie is saying, that it's a very high association, and also just by breathing against an incoordinated, swallowing against an incoordinated breath, they tend to swallow a lot more air, and these children tend to have a lot more air, so that the sphincters stay open for longer, and then the reflux comes up. And so that just makes everything worse. And also the angle of the larynx is much more anterior in the children with laryngomalacia, and some of them certainly have a micrognathia. So when they lie down, when they put down as they lie, the angle of the larynx, especially the posterior area, almost bathes in their secretions at the back. So it's just anatomical, physiological, and just the coordination that they have. So it's just just exacerbates it in all of those ways.
So I guess what I'm getting at is, do you think the reflux unmasks underlying laryngomalacia that's there already structurally, just by causing some edema and other changes, or do you think it's a cause and effect of the actual laryngomalacia?
Is that one for me or Aggie? Sorry, Prof. Aggie, you answer, and then I'll answer after you. I'm sure we're the same.
I think it could be a bit of both. Chicken or the egg.
Yes, I mean, I think it's not an exact science there, Prof. I think sometimes it does unmask an underlying laryngomalacia, especially when it's a little bit of an older, like a few months older. But certainly it's the laryngomalacia that they start with, because they present with a breathing issue. When you have a secondary manifestation of airway obstruction, and this is something I always say, and this is baseline, is you've got a primary airway obstruction or you've got a secondary airway obstruction. The primary airway obstruction is when they are struggling with having anatomical laryngomalacia and the effects of that. When they have a feeding difficulty that manifests as an airway obstruction, that's a secondary airway obstruction. That says when they feed or when they start getting ready to feed, and the stimulation of that precipitates an airway obstruction, then that's the main issue. So you get patients with low tone who have reflux going all the way up to their nose. At baseline, they are symptomatic from the airway. And then you get the patients who have reflux that are milder, but then they precipitate airway symptoms when they're feeding or when they're sick and things like that. So I always go down to the basics of whether it's a primary airway issue or a secondary airway issue. And the reflux is secondary. And those kids are the ones who actually struggle even on PPIs, who end up with other interventions.
Thank you.
Welcome.
Thank you, Prof. Thanks, Prof. Pierre. Are there any other questions or comments from the floor? I don't see any hands raised. You're welcome.
There's just one thing I wanted to add, Louisa, sorry to interrupt you, is just, I must say I've become very humbled over any interventions, especially surgical, in the supraglottis over the years. Even something very simple like a papilloma in the laryngeal surface of the epiglottis or along the aryepiglottic fold. The supraglottis is very unforgiving with any trauma or any injury or any condition. And so when we do supraglottoplasties, we're extremely respectful and we always do them with cold steel. There are many people who do them with laser. And I think my worry is, and I've seen this over the years, is a thermal injury with laser can have a knock-on effect on the superior laryngeal nerve that comes off. And it's not too far away if you think about millimeters in these children. And it ends up rendering that child almost like a laryngeal cripple because they aspirate. They've got loss of sensation certainly on that side, on the ipsilateral side. And so I think I always say with caution is not to use laser in neonates or in children in the supraglottis because of the dynamic effect that it can have. So I always do them cold steel, and the bleeding is not an issue, and certainly access is not an issue. So I just always humbly put that out there for people who do use laser, because we've seen quite a lot of, we've seen some bad outcomes with laser from other centers. Thanks.
You can certainly see the same thing with adults. You try and reverse supraglottic soft tissue stenosis. Whatever you do is almost impossible compared to when it's a laryngeal. It's really complicated. As you say, it's very unforgiving. It just starts going down.
Yeah, and there's nothing you can really do to reconstruct that. You know, it's very difficult to reconstruct an epiglottic issue or an aryepiglottic issue or a cricoid. I mean, sorry, an arytenoid issue. You know, you can do everything in the glottis and the subglottis, but certainly for the supraglottic area, it's just so hard to recon.
We've just got a question from our fellow Dr. Rasmus Agata.
So my question is about the stride post supraglotoplasty. Can we use the stride as a marker of success of the operation? Does the stride immediately disappear after the supraglotoplasty, or can we use other parameters to monitor the success of the operation?
So just I can confirm, you're saying the stridor post-op, is that a sign of improvement or change? Is that what you're?
Yes.
Okay, all right. So yeah, so usually they're a lot noisier post-operatively because of the manipulation and because of being in a narrow, small space. And they usually settle, and it's really, really important. That's why we've done the SOP. It's really important that when they get transferred to the ICU, that they are in a very comfortable, deep sleep type pattern, because if they're awake and they're screaming and shouting, it just increases a lot of blood flow to that area and stimulates inflammation. And actually they can get hoarse with just being awake and being irritable and all of that. So we always recommend that in the first 24 hours, they're actually in a nice deep sleep, not obviously deep enough where they need support, but we give them a nice high flow, nasal high flow, and they are on a Presidex infusion or something that calms them down. Because as we know, Laryngomalacia, when a child is asleep, goes away. So we know that the airway is supported in the most comfortable way when they're asleep. And then what we do is we notice when they are awake and when they feed, we have a speech swallow assessment first. We stay away from any milky or products or anything that will induce acid in the first 48 hours. And we check first that they're not aspirating or choking, because that can also increase stridor. And usually the stridor will settle in the first 4 or 5 days, but we keep them in the hospital for that time just to make sure that they don't have a biofilm or they're not aspirating or anything like that. And then the full effect is 6 weeks. And some people even go so far as to do a sleep study. So they would do a sleep study pre and a sleep study post, just to see an objective measure. Because a lot of these things are clinical judgment and expert opinion. You know, have they improved? Have they not improved? And what's the difference? But certainly by 6 weeks, they're a changed child. A lot of parents would say that they sleep through the night now. And I think that's sort of the marker. We check their weight and their gain and things like that.
Thank you.
Thanks, Prof. Pierre. Are there any more questions or any more comments from the floor? Anyone else joining us? Okay, I don't see any more raised hands or any more questions or comments. Thanks for a nice presentation, Aggie. Thank you everyone for joining us. We're going to end the meeting and we'll see you all next week.
Thanks, everyone.